To our conversations on brain health hosted by the Neurological Alliance of Ireland as part of our programme of events for World Brain Day 2022. I'm delighted to be joined by Professor Ronan Collins, National Clinical Lead for Stroke. Professor Collins, the theme of World Brain Day this year is brain health for all. And could you just comment on the challenges and opportunities as you see it involved in addressing brain health here in Ireland?
Well, I think the first thing to say is I very much welcome the opportunity to be part of this initiative and indeed World Brain Health Day. I think it's important when I reflect on it to realize where we've come from as well, so we probably don't make the same mistakes. For some reason, the brain seemed to be the last end organ to attract the significant attention of medicine and indeed the commissioners of healthcare, which is very strange given that we have a maxim within stroke medicine. Well, you know, the brain is the most important organ. It's the only organ you can't transplant. That's slightly facetious, but it used to sit above the CT scanners to make the point that if we have an acute stroke in the emergency department, get out of our way, we should have primacy because our organ is the most important. But I suppose when I reflect on it in my own medical career over the last 20 plus years, you know, even in terms of stroke, in terms of dementia, in terms of many of the neurological disorders, I won't say there was nihilism from those of us that were interested in those disorders, but the rest of the medical community seemed frankly disengaged about it. And it took us a long time, even within my own subspeciality of stroke, to get the attention of the commissioners of healthcare to change things. Of course, I say that because in order to change things at the time, we were very much focused on the acute presentations of acute stroke, dealing with people who were now very symptomatic with dementia. I know we've had Brian Lawler talking in one of these little interviews as well. And I suppose we have now kind of begun to address that acute presentation or that symptomatic presentation. And I think the real opportunity and the real challenge for us is to take this a step back and to be more preventative in terms of our brain health rather than addressing the symptomatic stage, to understand the etiologies behind these conditions. When can we first detect that a person might be at risk or is going to develop disorder, and can we intervene early, even if it is just with appropriate models of care and information and education in the absence of good medications, because putting in that foundation structure will lead to better treatment when the medications arrive, which they surely will. And I say this out of experience, for example, in terms of the stroke move, or if I can use the term, this pathway of stroke medicine. Before we had thrombolysis, before we had thrombectomy, before we had effective acute stroke treatments, we organized what we could. We put people who were knowledgeable and interested in stroke medicine in the cohorted areas to look after patients with stroke, to make sure stroke patients got the best treatment and education and their families got the best support and education we could at the time. And of course, then when the treatments did arrive, we had the infrastructure by which we could deliver them most effectively. And so I think it's useful to know that, but I think we need to also reflect that the challenge here is preventing and protecting people's brain health at a much earlier stage. And my last comment on that theme would be, although I'm a geriatrician by training, I think increasingly the focus of gerontology is not so much focused on maybe trying to address the care needs of older people alone, but also to try and say to the younger generation coming behind, listen, in order to age better, to age healthier, you need to invest before you're older. And I think that message holds true for a lot of brain health too.
Absolutely. And we were quite excited here in the Neurological Alliance when we saw the World Federation of Neurology adopting that theme of brain health for all, emphasizing that preventative approach. Just you were saying about your background as a geriatrician, do you think there's a need for a more integrated approach to brain health of the different specialities and areas of the health services working together a bit more?
Well, the Irish expression is ní náirc cur le chéile, and that's very, very true. I mean, as a geriatrician, I'm very comfortable working both interdisciplinary and multidisciplinary. You will always get a better outcome in terms of, if we integrate our services a bit better. I think you're increasingly in stroke has always been integrated. The best stroke services in this country are the ones that are integrated between, gerontology, neurology, rehabilitation, medicine. You get, and including psychological medicine, that you get the best outcomes. Similarly, for example, there are models around Parkinson's treatment, again, where you've got that similar integrated care and interdisciplinary care, which helps deliver the best care for the patient. And that care must also transcend from the hospital sector out into the community as well, to ensure that people who have, and many neurological conditions, as you know, are chronic, they do need that continuum of care, because many of neurological conditions, and stroke is no different, is punctuated by relapses, remissions, and review needed. And so we do have to have both integrated care between our disciplines and integrated care between our structures in the acute hospitals and in the community, to ensure that patients get the best possible outcomes in treatment terms.
And I know you were speaking there, that's about the pathway all the way through, from prevention right through to treatment. Do you think there's a particular part of that pathway that we've got very right? And do you think a part of it where we really still need to have a lot of work to do?
I suppose I'll be cynical and I'll say we've got none of it right. I say that a little facetiously, I suppose. We've got parts of it right, but in reality, you can't get a single part of it right without getting the whole of it right. It's a bit like saying, the house is finished, we've a functioning bathroom, but we've no kitchen, or we've no living area. So, I mean, I think you have to have all parts of it correct in order to make it really right. Because even in the acute part of it, and I think in terms of stroke, we've got some of the acute stroke care particularly right, particularly in Ireland. I would be particularly proud of our colleagues delivering the thrombectomy service. And indeed, we've got 24/7 thrombolysis widely available now, and we've got stroke unit care widely available. It's not resourced enough, but even those acute services can only work if there's a proper continuum to aftercare after hospital, because otherwise patients don't move through the pathway, or people will present again without the appropriate continuum care and secondary prevention. So they are very much interlinked. But I think, yes, we probably, if I was reflecting on our own area of stroke, I think we've got some of the acute care better and right. We haven't really tackled the preventative issue properly. And much of what prevents stroke is also good for brain health in general, both in terms of mental health, both in terms of risk of developing dementia. And so I think that's important for everybody. And I think also then in terms of our secondary prevention and the chronic disease management, we haven't got it right to date, but we are beginning to address that as well. Listen, it's a work in progress. We have challenges facing our health service, both economically in the coming years, but also from both a demographic and a sheer population number. I think people must realize, and we've been saying this for quite some time, and the recent census has backed this up now, there has been quite an extraordinary increase in our population in the last 8 to 10 years, probably the biggest accelerated increase in our population ever. I mean, for a country's population to increase by 20% in such a short period of time is a major challenge for us to make sure that our health services are fit to meet that challenge.
Absolutely, absolutely. Professor Collins, thank you for that. And I suppose my last question, you might have answered this somewhere along the line, is in terms of working with stroke, are there specific approaches that have been taken, things that have worked well in stroke that you think are applicable to other areas of neurological disease?
I think the first thing is to probably have a strategy. And we've been pushing this for some years. We're finally getting traction. And that strategy must be holistic. And what I say is, so we divided our strategy into 4 pillars: a preventative pillar, an acute care and cure pillar, a restoration to living pillar, and a research and education pillar. And each of those pillars are equally as important in ensuring that our stroke service will meet the needs of the population going forward. None of them is more important than the other. It may seem so, but they're interlinked and interdependent, and they actually make each other's segments work better if they're all properly resourced. So I think to have a strategy that's holistic, that looks at the whole area and doesn't forget research and education, not only for healthcare professionals, but including public education, which is very important. So people are aware of the issues. So I think having a strategy that meets those issues. The second thing I would say is that when you are producing a strategy, having been involved in 2 national strategies, one was the National Cardiovascular Health Strategy. It was a great strategy, but the lesson I learned was that it was too far-reaching. If you showed it to a commissioner of healthcare, they wouldn't know where to start. And so when you start your strategy, you must realize that this is a strategy of preferably over the lifetime of a government, because that will attract the attention of the sitting minister and government, that the work will be completed within that period. It will address things that we can realistically do within a 4 to 5 year period that are, number one, economically feasible. Number two, will have a high impact on patient care and patient care metrics. So the commissioners then have faith in your strategy that it is resulting in improvement. And as I said, that thirdly, it's clinically we're able to deliver it as well. If you do that, I think what you do then in maybe year 3 or 4 of your 5-year strategy is you sit down and you begin the process of review and the next step strategy. So again, you move it incrementally forward. I think, as I said, as I reflected on the cardiovascular health strategy I was involved in, it was a great document, but it was just too far reaching and you just wouldn't know how to bite it off and commission it, so to speak. So I do think it's important that strategies are designed to be holistic, but also achievable within a deliverable time frame.
Professor Collins, thank you so much for that, because what we're finding with this series is the different areas and branches in neurological care have so much to teach each other. And definitely your reply there to the last question about how to get a strategy right, I think is something that we really, I suppose other areas could definitely learn from and take on board. Thank you so much for participating in our Conversations on Brain Health series and sharing your insights this afternoon.
Absolute pleasure. Thank you for the invite, Mags.